Yeah, okay, thank you very much. So renal artery denervation, this is what we all learned at medical school about how blood pressure is regulated. You remember angiotensinogen, angiotensin 1 and 2, aldosterone. So this is what all you have learned about regulation of hypertension. But we know since about 15, 20 years that there are also nerves influencing blood pressure regulation, and these are nerves coming from the brain, efferent nerves going to the kidney, and they have some effect there on renin release, sodium retention, and renal blood flow. So this has been known since 15 years or so. But we know also now today that there are also nerves going the other way around, going from the kidney to the brain. And what they do is they increase the central sympathetic drive. And this has several other effects, for example, vasoconstriction and arteriosclerosis, but also hypertrophy, arrhythmias, and increased oxygen consumption of the heart. And there's also some effect on insulin resistance. So again, nerves coming from the kidney go to the brain, increase the central sympathetic tone. So that means the central sympathetic drive is directly influenced by the kidneys via afferent renal nerves, and the interruption of these nerves lowers blood pressure and may have other beneficial effects. There had been a surgical technique looking at this or using this concept, and that is thoracolumbar sympathectomy, which has been developed in the 40s and 50s of the last century. It's a very invasive procedure. It was very effective in reducing blood pressure and increasing survival, but it had a lot of side effects, mortality, surgical mortality. There was a significant morbidity, including orthostatic hypotension, bowel and bladder dysfunction. So for this reason, this surgical approach has not been used anymore. So how to do the same thing minimal invasively by catheter technique? Fortunately, the renal nerves follow the renal artery to the kidney, which makes them accessible to a catheter intervention. They lie primarily within the adventitia. What you need to do this is a generator which delivers radiofrequency energy with a maximum of 8 watts. It has some safety features like automatically switch off if temperature increases too fast or too slowly. Temperature, if the temperature is higher than 75 degrees, or if the impedance does not decrease sufficiently. You need the catheter, which is has a radiofrequency electrode tip. It has a handle which allows bending of the tip and rotation, and it's compatible with a 6 French sheath. This shows you the tip of the catheter, which is bendable and steerable. Some procedural details. You have to give premedication with aspirin. We learned during our early experience that this is a very painful procedure, or can be a very painful procedure, which means you have to give morphine and sedatives, 5,000 units of heparin, nitroglycerin, in order to avoid spasm. Can you still hear me? Yes. Okay. So you need a 6 French femoral sheath, a 6 French renal guiding catheter. You perform angiography of all renal arteries. You introduce a radiofrequency catheter and perform 4 to 8 ablations, 2 minutes each. This is the treatment strategy. So we introduce the catheter almost to the bifurcation. Then we perform focal ablations around the circumference of the artery in order to destroy all the nerves in the vessel of the renal artery. You can see an example. So the catheter is advanced towards the bifurcation. We perform the first ablation, pull it back, the second one, and so on. And finally, the last ablation is performed at the upper edge of the renal artery, because we believe that most renal nerves leave the renal artery at that point. We have a course about this in Hong Kong in September, and another one in March next year in Frankfurt, where we will also show other techniques of renal denervation. So where's the evidence for this treatment? There are basically 3 trials which are ongoing or finished. The Simplicity HDN1 trial was kind of first in man, single arm, and we did this with an extended cohort. Simplicity HDN2 trial was a randomized trial, and then Simplicity HDN3 trial randomized with sham control, which is still ongoing. Let's focus a little bit on the randomized trial, because this one is obviously the most important one. We published this in Lancet, 106 patients randomized 1-to-1 to treatment with renal denervation versus control. These are the inclusion criteria. So we use this technique only in resistant hypertension so far, blood pressure above 160 millimeters of mercury, 3 or more antihypertensive medications. These are the exclusion criteria. I think we can skip this here. Let's look at the complications or the safety of the procedure. What is very remarkable that is we had no serious device or procedure-related adverse events at all in all these patients included in this trial. No change in renal function. That is something we were very concerned initially. So no change in renal function. No severe hypotension or orthostasis. There had been some minor adverse events, but all unrelated to radiofrequency. And 6-month renal imaging showed no vascular abnormality at any radiofrequency treatment site. There was one possible progression of a pre-existing stenosis which did not need any further treatment. So very safe procedure. Many of you are familiar with the results of this trial. Primary endpoint was 6-month office blood pressure, which could be reduced by 32 millimeters of mercury, whereas there was no change in the control group. And the difference between renal denervation and control was obviously highly significant. 84% of renal denervation patients had at least 10 millimeters of mercury reduction in systolic blood pressure. Only 10% of renal denervation patients had no reduction in systolic blood pressure. So how does this compare to medical treatment in resistant hypertension? And I looked at the literature and some recently published trials in resistant hypertension with additional medication, and you can see what they could achieve, -12, -16, -22 millimeters mercury compared to -32 with renal denervation. So very effective treatment. So this is the change in office blood pressure again in the randomized group, and this is 12 months post-randomization. So this is 12 months post-renal denervation, and these are the patients who underwent crossover after 6 months, and you can see that we could achieve almost the same effect in these patients. This shows you the percentage of patients who had controlled blood pressure. So this is baseline renal denervation. This is after 6 months. You can see that about 40% had normal blood pressure and about 80% had reasonable controlled blood pressure. And this effect was persisting up to 12 months after the procedure. This is the crossover group. So bad blood pressure control initially at baseline, pre-renal denervation after 6 months, again, bad blood pressure control, and a huge improvement 6 months post-renal denervation in this crossover control group. Subgroup analyses, age, gender, and diabetes had been analyzed. There was no differences, so effective in younger and elderly patients, in a man and female, and also in diabetics and non-diabetics. What about long-term safety? And now I would like to go to the initial trial, the HDN1 trial, because we have now follow-up for 3 years. There was one progression of a pre-existing stenosis, which underwent stenting without further sequelae. There was one new moderate stenosis, which was not hemodynamically significant and needed no treatment. 3 patients died, all unrelated to the device or therapy. No hypotensive events that required hospitalization, and no change in renal function or in electrolytes. What is the time course of the effect? Simplicity HDN2 trial, the randomized trial. This is after 1 month, 3 months, 6 months. So it's an increasing effect over time, and it's long-lasting up to 12 months. And this is HDN1, where we have 3 years follow-up. You can see it's an increasing effect over time, a persisting effect up to 3 years after the initial procedure. Percentage of blood pressure control, again, up to 3 years. You can see reasonable control to good control blood pressure in 80–90% over time. And when you look at the rate of responders, you can see that it's an increasing effect. So we had 100% responders after 3 years. And if you look at those patients who had been non-responders after 1 month, they still tend to respond after 3 months, 6 months, and so on. So it's a late onset of the effect with renal denervation. What's about renal denervation and chronic kidney disease? We have some data in these patients, severe renal failure. They underwent renal denervation. You can see blood pressure was reduced as well in these subgroup of patients, and renal function remains stable. So renal function does not get worse if you do renal denervation. What's the future of renal denervation? Does it work in less severe regions? Because the effect is a long-term effect, so there is no immediate feedback possible.
Can we proceed to the case if you have a live case
right
now?
Mm-hmm. So welcome everybody. Today we will show you a case of a radiofrequency ablation of the renal arteries, and we will start with some background information about the patient and the history of the patient, please.
This is a 55-year-old female patient with arterial hypertension since 1999. Her office blood pressure was 182 to 100 millimeters in mercury. Her medications is candesartan 60 milligrams, hydrochlorothiazide 12.5 milligrams, metoprolol 50 milligrams.
So what I have prepared is a 6-French sheath in the right femoral artery, and I'm going to introduce a renal guiding catheter. Patient has received 6,000 units of heparin and also some analgesics, because sometimes this procedure may be to some degree painful. Okay, so what we see here is one single renal artery on both sides. There may be an infrarenal aneurysm above the bifurcation, which is not important for this procedure here. We see a little bit of wall abnormalities on the left side. I think that's not an issue. We don't see any significant lesion. We now have a standard renal guiding catheter, so especially looking at the right renal, it may be better to use an IMA guiding catheter, 6 French. So now we'll start with the right side. So here we are. Okay, this image again confirms that there is most likely no additional renal artery, because we see branches going all over the kidney. So now we are basically ready to introduce the radiofrequency catheter. This has to be connected to the generator by the cable. It has to be connected right here. So there are basically 2 ways to steer this catheter. One is with this knob here. I can flex it like this. And like this is actually the old version of the catheter, but it's the new version looks quite similar, and the steerability is comparable. So before we start the procedure, we give 0.2 milligram nitroglycerin selectively into the renal, and we are also supposed to do ACT. So now I'm introducing the Simplicity catheter. So I will advance that catheter up to this bifurcation, like here, and now I will flex the catheter, which will bring the tip to the vessel wall. The patient is already on analgesics. We give usually morphine, 10 to 15 to 20 milligrams, maybe with some additional sedation like midazolam. Okay, this is a good starting point. Now we look at the generator, and there we can see the temperature, which is currently 37. Impedance is 256. So now we can start the first energy application with the foot switch here.
The generator was designed specifically for renal artery application. As you can see in the bottom left corner, the power is ramping up. It takes feedback from the catheter tip to measure the impedance in the bottom right corner and the temperature in the top right corner. And based on this feedback, it'll change the power settings automatically. If it senses there might be some kind of movement or an error, the machine will automatically cut off. You can see the time in the top left corner, and this is a total of a 2-minute ablation.
So 3, 2, 1 second, and we are finished. Okay, so now I will pull back the catheter and rotate it at the same time. And I also changed the configuration of the tip. So we started at the upper rim or upper edge of the vessel, and now I pulled it back a few millimeters and flexed it differently. So now it's pointing towards the lower edge of the vessel wall. So we can start the second energy run. So I will continue with this and go back each time about 5 millimeters. I will always rotate the catheter so that we cover the whole circumference of the vessel. What is important is to avoid side branches. So there's a suprarenal artery at the ostium. We should avoid to engage that with the catheter.
So we noticed we just had an error message. That the generator has built-in algorithms to track the temperature and impedance, and if the wall contact is not adequate, it will automatically turn off and require a new position to be maintained.
Can rotate a little bit more. Like that. Okay, what is the impedance? 209, 250, 48. So we had one for 2 minutes, we had one for 1 minute, and then it stopped, and now we are doing the third one. So I'm rotating again a little bit.
Horst, excuse me to interrupt you.
About 5 millimeters.
Horst,
now
it
we are again
remains
at the upper
4
edge
minutes.
of the vessel. Impedance is 237. Sorry?
Horst, it remains between 3 and 4 minutes because we have another live after you.
Okay. I think actually, and impedance is 250. I think in that case, I should probably stop here because what you will see is just the same thing again. So maybe you can use the remaining time for questions if there are any.
One practical question. When you have an early division of the renal artery or you have a axillary renal arteries, do you go in the all arteries and do it?
I always try to treat as many renal arteries or renal artery branches as I can. There is a limitation regarding size, so the diameter of the vessel should be at least officially 4. And in daily practice, you can go down to 3 or 3.5. There's some increased risk of spasm in smaller renal arteries. But I try to answer your question, I try to treat as many branches as I can.
Okay. But if you have a very early bifurcation, how do you go into each branch, major branch?
Exactly. Then I go into each branch and I perform at least 4 ablations in each of these branches.
The other thing is we in India are still waiting for this device to come. The drug controller doesn't allow us to use the RDN device, but some of my colleagues have started using the standard EP catheters to ablate the renal arteries. What's your suggestion on that, and what do you think about it?
Yeah, the main problem is that, as we just discussed earlier, there is no kind of feedback whether you are effective or not. And I mean, this device has been tested in a randomized trial, and it has an internal algorithm to adjust the energy to the heat and to the effect which is obtained. That's not the case with a regular EP catheter. So I know that it probably works, but it's difficult for the individual patient, and there are some risks that you do something which may be wrong, which may cause scar tissue formation or whatsoever. So all this is a little bit unsafe.
And how many of the patients do you treat are actually having diabetic autonomic neuropathy? Because if they have a diabetic autonomic neuropathy, they are practically they have a denervation already. Do these subset of patients also benefit from radiofrequency ablation?
Well, we only know that the treatment is effective in diabetics as well. So there's no difference in the responder rate between diabetics and non-diabetics. So theoretically, yes, but in daily practice, it doesn't play a role.
After renal denervation, how many patients in your practice were off medication after the procedure?
That's a good question. The primary aim of this procedure is not to stop medication. It's to decrease blood pressure. And we always recommend to keep the medication on the same dose. Nevertheless, some patients could reduce their medication, and there are a few patients who could completely stop. But it's not that we are able to cure hypertension. We just can reduce blood pressure a little bit, which is very important regarding stroke protection. But it's important to educate the patient they should not stop their medication.
And you have to do it on both the sides, right renal artery as well as left renal artery.
We do it always on both sides, but if for some reason we are not able to do it on both sides, for example, very small renal arteries on one side, the treatment is still effective. We don't know whether it's as effective if we can treat both sides, probably not as much, but it's still effective.
Thank you very much, Dr. Seward.
Yes.
I hope next year you would be here in person. I'm very thankful to you that you could at least make it on through the satellite and internet, but next year probably we'll be having you here. Thank you so much.
Thank you very much.